Good morning, everyone. I welcome you all for the second day of ATAL-sponsored online FDP on Fostering Brilliance, Life Skills for Women's Professional Excellence. Dear participants, today we will be having 3 sessions, 10 a.m. to 11:30. The topic would be screening strategies for women's cancers, practical testing and early detection protocols. And the session would be delivered by Dr. Joylyn D. Almeida. The session from 11:30 to 1 p.m. would be healing through movement, dance for mental health and emotional expression. The resource person will be Dr. Priya Alva. Afternoon session, that is 2 p.m. to 3:30. The topic will be building positive mindset to tackle stress, and resource person will be Dr. Malini Hebar. We are starting with today's first session, and it's my honor and privilege to introduce our distinguished resource person, Dr. Joylyn D. Almeida. Dr. Joylyn D. Almeida is a distinguished consultant obstetrician and gynecologist and an accomplished laparoscopic surgeon, currently serving as an associate professor in the Department of Obstetrics and Gynecology at Father Muller Medical Hospital, Mangalore. She holds an MS in obstetrics and gynecology and has completed a fellowship in minimal access surgery and laparoscopy from the World Laparoscopy Hospital. In addition, she has pursued PG diploma qualification in clinical research and medico-legal system from Symbiosis, reflecting her keen interest in research, ethics, and evidence-based medical practice. Her areas of specialization include high-risk pregnancies, adolescent gynecology, preventive gynecology, and advanced laparoscopic procedures. Dr. D. Almeida is actively involved in undergraduate and postgraduate medical teaching and is recognized for her role in capacity building and skill-based training. She serves as a state trainer for obstetrics in emergency comprehensive life support, is a FOGSI approved critical care obstetrics trainer, and works as a medical simulation adjunct faculty. She also trains rural primary health center medical officers in comprehensive obstetrics and gynecological procedures, contributing significantly to strengthening maternal health services at grassroots level. An active academician, Dr. D. Almeida has delivered numerous seminars and awareness programs on antenatal care, cancer awareness and screening, PCOS and adolescent health, and menstrual hygiene. She has organized and chaired several obstetrics and gynecology conferences and many others. Her professional affiliations include active membership in Mangalore Obstetrics Society, National FOGSI Critical Care Obstetrics Committee, PCOS Society of India, and many others. Dr. D. Almeida is deeply committed to community engagement. She is the co-founder of Moms of Mangalore. She is also a key member of various women's health campaigns and regularly delivers radio talks, television programs, and webinars to promote the health and well-being of women and adolescents. With her blend of clinical expertise, academic leadership, training excellence, and community service, Dr. Joylyn D. Almeida continues to make a meaningful impact on women's healthcare and medical education in the region and beyond. With this brief introduction, we extend a hearty welcome to you, madam.
Thank you, ma'am, for the very kind introduction.
I extend a warm welcome to our director, Dr. Seema H. Shenoy. Welcome to you, ma'am. A warm welcome is extended to all the participants. Welcome to you all. Now, I request our resource person, Dr. Joylyn D. Almeida to address the participants. Over to you, ma'am.
Thank you, ma'am, for that very kind introduction. At the outset, I would like to thank the SDM College of Business Management and Postgraduate Studies for this honor and this opportunity. Dr. Harshita and the entire team for organizing such a good array of topics and a very innovative and educative seminar for all the participants. I hope at the end of end of my session, particularly, you will be able to take home some messages, not only on the academic front, but also on the personal front in terms of cancer screening. Can I begin, ma'am?
Yes, ma'am, we can start.
Yeah. So I'll just share my slides and
Yes.
I hope this is visible. Yes.
Yes, ma'am.
Right. So the topic that I have been allotted to and I would like to share with you today is about saving lives early, screening strategies for women's cancers, practical testing and early detection protocols. Now, cancer is a one word that can, frighten anybody and everybody. And that's the one thing that we're all scared about. When we talk about a health checkup or a medical checkup and we tell someone, get a health checkup done, the first thing that comes to our mind is whether we say it or not, is that whether we have the chance of having cancer. So that's how the word cancer usually scares everybody. But before I begin what I have to talk to you about today, I'll start off with a quote. It says, "Hope is like the sun, which as we journey toward it, casts the shadow of a burden behind us. And screening in cancer is like hope." So we walk towards the sun, and as we're walking towards the sun, all the burden of the disease that we carry has to be left behind us. So, cancer screening would mean that we have to screen the entire population or the normal population and look for chances that they may develop cancer. It does not mean that somebody has cancer, so we screen them. So, a big chunk of my talk today is going to be about what you understand about screening and why do we need to screen. The major reason here being India's cancer burden has doubled over the last 26 years, and cancer is known to be the second most common cause of mortality or death. And this is how grave the problem is. And that is why, when cancer screening is done and cancer is picked up in any part of the body in early stages, it can have as good as 100% or a complete cure. So, the objectives of screening, when I say cancer screening, what do I mean? When I have to explain it to my patient, what do I tell them? I tell them that, see, it doesn't mean that you have cancer. We are screening you because we want to pick up precancerous lesions or very early stage cancers. When we pick up these lesions and we treat them effectively, overall mortality in our country because of cancer comes down. We identify high risk women, especially when we do cancer screening and we take history. And family history is very, very important because if I have two individuals and one individual has no family history of cancer and the other individual has history of cancer in more than one first degree relative, like a sister or a mother or an uncle or a father, if they have a positive family history of cancer, they become high risk women, and that means they have to undergo screening more frequently than the individual who doesn't have a family history. So while I'm doing screening for cancer, I would give a lot of importance to family history and genetics. Also, when I look at a screening test, when I say screening test, I would screen the entire population, the general population. I would subject them to a test, and from that screening test, I would pick up the high risk women and then subject them to a biopsy or a confirmatory test. So, a biopsy is another word that really, really scares people when we say it in terms of medical terms. But biopsy doesn't mean anything other than confirming whether there is cancer or not. So, any screening test that we choose has to be cost effective. It has to be economical, affordable, accessible to the entire population. And in women's cancers, the two screening tests that are readily available like this are a pap smear for cervical cancer and breast examination for breast cancer. So, those are the two screening tests that are used for the common women cancers. And once we screen the patients, we can ensure that there is proper referral. We refer them to a higher center. We can diagnose the disease on time and we can treat the patients effectively. When I talk about women's cancers, there are four cancers that I would cover upon in my session today. First would be cervical cancer, which is a cancer of the mouth of the uterus. I'm not sure if the pointer is visible, but yeah. So it's the cancer of the mouth of the uterus, which is called a cervical cancer. Breast cancer, we all know, is one of the most common malignancies in women in the country. So most common cancer among women is breast cancer, especially in India. In cervical cancer was on the rise. The incidence of this is slowly coming down because of effective screening by pap smear, which is screening of the mouth of the uterus for cervical cancer. Ovarian cancer is cancer that happens in the ovaries. It is the most deadliest and the most mortal of the cancers, and the one that we really worry about, because usually these cancers are diagnosed late and there is no effective screening test for ovarian cancer. The effective screening tests that we do have are pap smear for cervical cancer, and of course, we do breast examination for breast cancer. Endometrial cancer is also detected early because of its symptoms, and hence it's one of the relatively better cancers to have, because we pick up endometrial cancer or cancer of the body of the uterus very early, and hence it has a good prognosis. So these are the four cancers: cervical cancer, breast cancer, ovarian cancer, and endometrial cancer. Of this, ovarian cancer is the worst to have, and endometrial cancer, cancer of the body of the uterus, is one of the ones that are picked up very early. Cancer screening. Our current situation of cancer screening is not very great. Like I said, the moment we say cancer, the moment we say screening, people get really panicked out and they think there's a problem, which is not true. How I explain this to lay people is that, when we have a car or a aircon at home, and or a refrigerator at home, we don't wait for those devices to get spoiled and service them. So we do a servicing, or we do an annual maintenance of that device before the device actually gets spoiled. And I would equate the body to something like this, where we doing a screening or doing a health checkup is like doing an annual maintenance, or a check of your body to make sure that bigger problems don't come up in the future. So that's exactly what cancer screening is about. It's basically a misnomer or a myth when people think that it is something scary. Women between the age of 50 to 69, only 37% of patients have actually undergone a mammogram at any point of time. Whereas after the age of 50, it is compulsory to undergo a mammogram every 2 years, or at least every year. Less than 1 in 2 patients have actually undergone cervical cancer screening, which is the most common gynec cancer in our country. Less than 1 in 2 women actually have undergone screening. And these statistics are even poorer in the rural areas. 41% of women between the age of 50 to 74 have undergone a colorectal cancer screening. Again, a very small number for colon cancer. So in India, it's breast, lung, and colon, which are the most common cancers that we see. And even then, only less than 50% of women have undergone screening for colorectal carcinoma as well. What is our principle? Whatever condition that we're screening has to be a major health problem. We should be able to pick it up in the preclinical phase. The screening test that we're using has to be simple, safe, and affordable. We have to have facilities. So almost all PHCs as well as hospitals have facilities for a pap smear and a mammogram, which is very much required. And whatever test we're doing, for example, a pap smear, and I would use this as a gold standard test in terms of screening to explain to you, the benefits of that screening should outweigh the potential harms. And that is what a good screening test is about. Coming to the first cancer, which is cervical cancer, India accounts for 1/5 of the world's total number of cervical cancer cases. Second most common cancer in India after carcinoma breast, accounts for 79,000 deaths annually. Although the incidence of cancer of the mouth of the uterus, which is cervical cancer, has relatively come down, we still see these cancers. And the reason why this has come down is because of two reasons. One is because of pap smear, which is an effective screening strategy. The second is because of the HPV vaccine, which is now being part of the universal immunization schedule, is being given to all children between the age of 13 to 25. This has effectively brought down the incidence of cervical cancer along with the pap smear screening test. All over the world, 660,000 cases occurred in India and China, especially in 2022. Cervical cancer, the main reason or the main cause behind cervical cancer is HPV infection. And that is why the HPV vaccination is being advocated for children between the age of 13 to 25. What happens in cervical cancer is, as soon as the HPV infection happens, it doesn't mean the patient will develop cancer immediately. Just before the patient develops cancer, there is around a 10 or 15-year gap in the period of which the HPV infection can either get cleared away, or the infection can proceed on to pre-malignant lesions or malignant lesions. The incidence of cervical cancer is high in low and middle-income countries, and the screening in cervical cancer is one of the most effective screening strategies of any screening test that has been discovered. And pap smear has helped reduce the incidence of mortality and morbidity because of cervical cancer, which happens in the mouth of the uterus very much. So when we do an examination on a patient in the OP or the clinic, we see the cervix, which is the mouth of the uterus. If we see a tumor or a growth which is this big, we don't do a pap smear. We do a pap smear only in patients the cervix or the mouth of the uterus appears normal, because that is the principle of a screening test. We do a screening test in patients in the general population who are normal and pick up very early lesions or precancerous lesions. Now, this is a lesion which is very large and it's actually a cancerous lesion. So, this lesion would ideally require a biopsy, because we already know that there is something there that looks suspicious. The screening tests for cervical cancer are many. The most common and the popular one is a pap smear. Now, when the moment you tell a patient, see, you have to undergo cervical cancer screening, you need to undergo a pap smear, there's a lot of panic. They say, oh my God, what is it, a painful test? And I think almost every day I answer 10 or 15 patients who ask me if the pap smear is painful. So that awareness about the pap smear still has to go a long way. Pap smear is a test for cervical cancer screening. And what we do in this is basically we examine the patient. We take a small brush. One of these brushes here is actually the pap smear brush. So we take a small brush here like this and we insert it into the mouth of the uterus. We smear it onto a slide and we give it to the laboratory and ask them to look for cancer cells. So that is what a pap smear does. So I tell patients, and I always tell patients, it's a very small OP procedure. It doesn't require any anesthesia. It's not painful. It causes minimal discomfort, sometimes no discomfort at all. And it will take hardly 5 to 10 minutes. You cannot do a pap smear when you're on your period or when you have excessive vaginal infection, but you can do it any other time. And it is recommended for women who are sexually active after the 3 years after sexual activity or from the age of 30 to undergo a pap smear once every 2 or 3 years. Now, I'm saying 2 or 3 years because the guidelines say 2 years, but most women hardly get a single pap smear done in one lifetime. So, after the age of 40, it is highly recommended that you do a pap smear once every 3 years. The second way of screening for cervical cancer is the HPV DNA testing. What do we do in this? So, again, we take a small brush, we rub the mouth of the uterus, and we send this to the lab. Now, we tell the lab, please look for HPV DNA because we know that HPV DNA is high risk for cervical cancer. So if I have a patient who has an abnormal pap smear, along with that the HPV DNA is positive, that means my patient is at a very high risk for cervical cancer and I would subject that patient to a biopsy. There's something called as a VIA, which is basically an Indian jugaad for screening. It's called as a visual inspection under acetic acid and the similar thing called as VILI, which is visual inspection under Lugol's iodine. Now this was a low cost point of care test which was discovered to make cancer screening more effective. See, we realized that people in rural areas and villages did not have access to come to bigger hospitals, or they were shy, or they were scared, and they wouldn't come. So we decided that we would send the auxiliary health workers or the village health workers to the patient's houses. So a lot of village health workers and a lot of auxiliary health workers, ANMs, midwives were trained to do a simple inspection of the cervix. They were taught, okay, this is a normal cervix and this is an abnormal cervix. Put a speculum and see. So they would go to the patient's houses, they would counsel them, take their consent, and then they would examine the services. And what they were given was something called as acetic acid and Lugol's iodine. So they were told, you go and dab a little acetic acid and see. If the cervix looks abnormal, then you call the patient to the hospital. So this was a low-cost point-of-care screening test, which is called as VIA or VILI. Not very commonly done in the cities and the urban settings, but very commonly done in the rural settings, where the auxiliary health worker goes to the patient's house, examines the cervix with Lugol's iodine or acetic acid, dabbing it on the cervix, and brings those patients who are high risk. Again, it's a screening test because you do it on all patients and bring them to the hospital. Now, the choice of our test will depend upon the resources and the population. Of this, the pap smear is one of the most important tests that are done. You must understand that when you go for a pap smear, sometimes they may ask you, do you want an LBC? And LBC is actually a better version of a pap smear. It is called as liquid-based cytology. To give you a rough analysis, where a pap smear costs anywhere between 200 to 300 and LBC will cost 800 to 1000 bucks. So that's the difference between the two. And as we know, with everything good in life, something expensive is always a little better. So although pap smear is very effective, the LBC is a little more sensitive to cervical cancer cells as compared to the pap smear. So the protocol is we start at the age of 21 years regardless of sexual activity and repeat every 3 years. In India, we do it 3 years after first sexual debut. But between 30 to 65, we recommend that every woman undergoes a pap smear cervical screening test to be done every 3 years. And the moment the patient has an abnormal result in the pap smear, we then subject that patient to a colposcopy or a cervical biopsy. So when we do a biopsy, like I showed you in that patient who had that cervical growth, we take a piece of that growth and we send it to the lab for a test and then we ask them to give us a report. So this is exactly how a pap smear is done. We place the patient in lithotomy position. An instrument called as the speculum is inserted into the vaginal opening. The cervix is then rubbed with a brush, or this is a cyto brush and this is an LBC brush. So we rub it with a brush and put it on a slide and give it to the lab for a test, and they look for abnormal cells and tell us what the pap smear report is. HPV DNA testing is recommended, highly sensitive for pre-cancer, every 5 years if negative, and longer screening intervals. HPV DNA testing is not routinely used. It is used in patients who are high risk because it is expensive. And when you do an LBC test, you can do an HPV testing in the same setting. But when you do a pap smear test, you have to take a separate sample for an LBC. So that's another disadvantage of doing the pap smear. But HPV DNA testing now is in vogue in a lot of metropolitan cities where routinely an LBC with HPV DNA testing is done. It helps us to triage the patient better. When I say triage, what do I mean? If there's a patient who has a normal pap smear and a patient who has an abnormal pap smear and a patient who has an abnormal pap smear with an abnormal HPV DNA, my patient who has an abnormal pap with an HPV DNA, I'm very clear about what to do with her. But if I have a patient with an abnormal pap and I have not done the HPV DNA, I have to be a little more stringent with my screening action. So that's the only difference. HPV DNA testing, although is one of the screening tests, is not routinely or universally done because of its cost effectiveness in the Indian scenario. Now, there is something called as an HPV DNA self testing, which is very much in vogue by the WHO. WHO highly recommends this, especially for women who do not come to the hospital or to the care center to do a cervical cancer testing. They recommend doing an HPV self-test. So they give you a self-test kit. The woman can do an HPV self-test by inserting the self-test kit into the vagina and looking for the HPV virus. And this is recommended by the WHO. This is something which is new. It's called as a HPV self-sampling, a convenient private way for individuals to take their own vaginal swab. And in this, we don't look for cervical cancer cells, but we look for the human papilloma virus testing. And this is called as the HPV self-test, which is a new thing in screening for cervical cancer. The next cancer that we come to is about breast cancer. It's like the elephant in the room. Everybody knows it's there, it's big, it's occupying. The incidence of breast cancer has drastically risen over the last few years. The number of patients I see every day who come with breast lumps has also gradually increased. This means that because the number of cancers in younger women are increasing, earlier we used to see breast cancer very much in postmenopausal older women. Now even younger women, women who have just delivered, pregnant women are also turning up with breast lumps. Most of them are non-cancerous, a few of them are cancerous, and that is why the incidence of breast cancer is 1.38 million new breast cancer cases every year. Every 4 minutes, an Indian woman is being diagnosed with breast cancer. Every 13 minutes, one woman dies of breast cancer, and 450,000 deaths from breast cancer happen every year. And this is the graveness of the nature of the disease, the nature of how big it is, and how breast cancer needs to be tackled. Now, how do you screen for breast cancer? There are three different ways in which we screen. There are many ways in which we screen, but the three common ways are breast self-examination, which is called as a BSE, clinical breast examination, which is done by a breast examiner, and a mammography, which is gold standard screening test. So you will notice that throughout my presentation, I will be talking a lot about the cervical cancer testing, which is pap smear, and also about the mammography or the breast ultrasound, which is done for breast cancer. Because these are the two cancers in which screening has been really effective, and we've been able to pick up the earlier lesions in breast and the cervical cancer, and this has really helped us. The other end of the spectrum is ovarian and endometrial cancer, where there are not very good screening tests. Endometrial cancer, the patient will come early with bleeding, but in ovarian cancer, it's one of the most dreaded cancers to have. So breast cancer, this breast self-examination, clinical breast examination, and mammography are the most effective tools. Most of us know what a mammography is. In a mammography, it's basically an X-ray. So the woman's breast is pressed against an X-ray plate, and X-ray is taken. The density of the breast is seen as an X-ray, and lesions are picked up. So if you see a certain lesion on an X-ray, on a mammogram, you can suspect. So this is called as a breast mammogram. We have digital mammograms that are available now, which are very effective. I personally don't recommend this test routinely because it's slightly painful. I would say it's more painful than a pap smear, but it is a very, very effective test. And every woman above the age of 50 is recommended to do a mammogram because the breast tissue is very thick. So there's always this confusion about the breast. Should we do an ultrasound? Should we do a mammogram? How often should we do an ultrasound and a mammogram? A mammogram is done for women above the age of 50 mainly because the breast tissue is very thick and dense, and any small lesions cannot be picked up in ultrasound. But in practice, above the age of 40, a breast ultrasound is as good, done by a good sonologist, is as good and as effective in picking up a cervical cancer. So there's different ways in which breast cancer can be diagnosed or screening tests can be done. One is a clinical breast examination by a trained examiner, a breast ultrasound, a mammogram, which is an X-ray of the breast, a breast MRI. If there are lesions which are very complicated, the MRI is not giving you the ultrasound is not giving you a clear report. We would do a breast MRI. When there's a lesion that is there, like I showed you the cervical cancer growth, if there is a lesion in the breast that can be seen, in that case, we would do a biopsy. So like I said, other than cancer, the other word that scares patients is this word called biopsy. Biopsy is nothing but a small needle test of the fluid that is there inside that lump. It is given to the lab for a test. And then the lab will analyze the cells and tell us whether there's any form of cancer or not. So this is how the breast screening is done. A nice depiction of the entire thing is clinical breast examination, a breast ultrasound, a mammogram, whatever is required. Complicated lesion, do an MRI, do a breast biopsy, and ultimately the pathologist will help us with what the cells are showing. So the screening protocol for the breast self-examination actually should start from the age of 20. In our country, we are a little, not very lax, and I don't see 20-year-olds coming for a health checkup unless they have any menstrual disturbances, unlike the West where everybody comes in for a health check. But a breast self-examination should start from the age of 20. Clinical breast examination, I would recommend for women above the age of 25 or 30 at least. Come for a clinical breast examination if the doctor, the gynecologist, the healthcare provider, the surgeon, whoever is doing a clinical breast examination on you finds a lesion, then you go ahead and do an ultrasound or a mammography. Now, above the age of 45 or 50, which is the target group, a mammography is recommended as part of a women's health checkup every 1 to 2 years. And we screen high risk women. Now, when I say high risk women, what do you mean by high risk women? More than two first degree relatives who have a history of cancer in the family. Let's say there's an aunt or a mother who has history of ovarian cancer or uterine cancer. They become high risk for breast cancer as well. So they are basically high risk women. So high risk women are nothing but women who actually have the genetics which are contributing towards cancer. So those are high risk women. So, right. So this was a very interesting slide that I came across while I was researching for breast cancer screening. And this is what to feel in your breast when you're examining and doing a self-breast examination. So self-breast examination is to be done once a month. Some people examine their breast every day, not to be done because ultimately at the end of the month, if you examine your breast every day, you will feel like you have some lump. So examine the breast only once a month, preferably after periods are over. Keep one day and do a breast self-examination. Look into the mirror, one hand above the head, palpate the breast. When you're lying down, keep your hand above the bed, palpate the breast up to the axilla. So this is how a self-breast examination is done. This slide is called as Know Your Lemons, and this basically tells you at the end of your periods when you examine the breast, these are the different parts of the breast. It's like a line. And if you feel a hard, immovable lump, which feels like a lemon seed, okay, which feels like a lemon seed, classically a hard lump which is not really moving, in those cases, it could be something that needs to be checked upon. It doesn't mean that every hard lump is cancer, but you have to get it checked. Lymph nodes basically feel like soft beans in the breast. So that's what it feels like. So a breastfeeding woman will feel something like peas. And these peas are nothing but the milk glands or the milk ducts. So these are the different kinds of, to explain to lay people when you do a breast self-examination, how it should feel. A lemon seed, peas in case of patients who are feeding, and lymph nodes are like soft beans. Okay, and this is called as Know Your Lemons. So another thing that Know Your Lemons teaches you is about what breast cancer can look and feel like. So you can find a thick area on the breast. You can find a dimpling in the breast. This is abnormal. So if the skin on the breast dimples or goes in, or the skin on the nipple starts crusting, all these could be signs of early cancer and should go and get a test done. If there's a growing vein on the lemon, if the nipple has completely sunken or gone in or retracted, we say, if there's itching or pain in one spot, a new shape or size, fluid is coming out. So any kind of breast discharge or nipple discharge which is bloody, watery, blood stain could indicate that there's something wrong there. Orange peel-like appearance of the breast skin, skin sores, and hard lumps. So this knowyourlemons.com tells you when you look at a line and sort of like equates that to your breast and tells you that when any of these lesions are seen, especially if this breast discharge or retracted nipples, when the nipple is suddenly gone in. See, some people are born with inverted nipples. That is not abnormal. But if your nipple was normal and suddenly it sinks into the breast, it could be a sign of early cancer, and that means you need screening. So again, a beautiful slide which actually summons up what you need. Find your symptom if you have a breast lump, confirm with the doctor, do a mammogram with the radiologist. They give you the results, either do a mammogram or an ultrasound. Then the biopsy is a needle test where the needle is taken into the lump, cells are taken, given to the pathologist, and the pathologist will now tell you whether it's cancer or not cancer, benign or malignant, and these are the various screening tests that actually can be used. So knowyourlemons.com is something that you would interestingly like to read about. It's by the Breast Cancer Organization. The next and the most dreaded cancer to have is ovarian cancer. Now, the thing about ovarian cancer is that it has such a high mortality because usually always diagnosed in late stages. See, when there's a cancer in the ovary, which is on the sides of the uterus, but when there's something inside the uterus, like a cervical cancer or an endometrial cancer, the patient will usually come with bleeding, and so we will get to know. But in ovarian cancer, unless the patient comes for an ultrasound every year and does a routine checkup, the patient usually comes to hospital in late stages. Along with that, just like there is pap smear for cervical cancer, ovarian cancer has no specific screening test, and that's the sad part about it. A lot of tests have come up like blood tests, proteomics, HE4, but none of them have been as good as pap smear has been in cervical cancer. So ovarian cancer is usually diagnosed very late, one of the most dreaded cancers to have, and has a very, very high mortality. The trend is rising, and the reason for this is our lifestyle. Bad lifestyle, bad eating habits, lack of exercise, patients going for excess amount of fertility treatment at a young age, especially patients going in for IVF, ovulation induction medication, injections. This has caused a rise in the ovarian cancer cases. It's the third most common cause of cancer among Indian women after breast, CA cervix, CA ovary, and 3 lakh cases are diagnosed every year. Every year, new cases of ovarian cancer are usually diagnosed. Now, the challenges in treating or screening for ovarian cancer is there is no screening test, there is no specific symptom. So we train our patients when they come for a health checkup that if you develop intractable gastritis or dyspepsia and it is not responding to antacids, then you have to go and get your scan done to check on your ovaries. So any kind of gastritis, indigestion, dyspepsia, which is not getting corrected by taking antacids or gastric medication, you have to go and get yourself screened and get an ultrasound done. So this is what we commonly tell patients, and that is the only specific symptom. There is no specific symptom for ovarian cancer. That is why it is diagnosed in advanced stages. And there are a lot of screening tests, but screening tests can give you a lot of false positives. That means I can do a screening test in the blood. It can tell me it's positive ovarian cancer, but the patient may not really have any cancer or a risk for cancer. So that's how the screening tests are not very effective, have a lot of side effects, have a lot of false positives, sorry, and the symptoms are very vague. And the thing about ovarian cancer is as it grows, instead of going into the uterus, it sort of like spreads into the blood and so the distance spread or the spread from the cancer is very fast. So in every way, ovarian cancer is one of the worst kind of cancers to have because it will be there in the ovary and instead of spreading into the uterus directly, it first spreads into the lymphatics and the blood. And that is why we see a lot of patients with ovarian cancer who ultimately have metastasis in the spine, in the brain, in the lung, and they come to us young patients in very late stages because it has not been diagnosed on time. So, I told you there is no screening test for ovarian cancer. It's the third most common cause of cancer death. What can we do? The thing about ovarian cancer is, as compared to cervical cancer or breast, I mean, not of course the breast, but endometrial cancer, breast and ovarian cancer are very, very strongly linked to genetics. There is a very, very strong link between genes, mutations, and family history and breast and ovarian cancer. So, if I have a patient who says, I'm having gastritis, indigestion, and it's not responding to antacid, I'll do a scan. When I do an ultrasound, I find that the patient has an ovarian cyst. When I find the patient has ovarian cyst, start talking to the patient and start taking history. And when I start taking history, I discover that this patient's aunt and mother had breast cancer, sister and somebody else had ovarian cancer, father and uncle had lung and colon cancer. So when there is a very strong family history of cancer in the family, breast and ovarian cancer have to be screened and genetic screening can be done. So genetic screening as such is not a very effective screening test. Again, I would compare genetic screening to pap smear. It is not affordable, it is not accessible, it's a very expensive test and the reports take a long time to come. That is why genetic screening is not as effective as a pap smear. But the pap smear is a cost effective test and is used for cervical cancer. But in ovarian cancer, where we have no screening test and it is very, very linked to genetics, first degree family history is very important in ovarian cancer. I would say that genetic testing can be done. So if I have a young girl whose mother has been diagnosed with breast cancer, sister is diagnosed with ovarian cancer, I would tell her, see, please go get your genetic testing done so we can screen you every year and pick up whether ovarian cancer risk is there. So family history is very, very important in ovarian cancer, one of the most dreaded cancers to have. So when you go to a genetic counselor or geneticist, what they will do is a pedigree chart. So this is a pedigree chart. They will draw the father, mother, children as a family tree and they will chart out who is affected and what is the risk of the patient actually having cancer. And then we will do a genetic screening on that patient because there is no other good effective screening test. These are some of the biomarkers and any patient who has an ovarian cyst, many of you would have heard this terminology called CA125. So CA125 actually is a blood test that is done in any patient with ovarian cancer. It is ovarian cyst. Any patient with ovarian cyst, we do a CA125. And usually in a lot of conditions like fibroids, chocolate cyst, the CA125 will be elevated. But CA125 is also elevated in cancer. I'll take a short 1 second break and see if I'm still audible.
Yes, ma'am.
Ma'am, I'm heard, right?
You're audible. Yes, ma'am.
Yes, ma'am. This is no feedback coming from the opposite side. I'm just worried the internet will go off in between. I'll keep talking. Anyways, thank you, ma'am. So, CA125 is actually a tumor marker and it's actually a blood test. So, even if a small 10-year-old girl comes with an ovarian cyst, I would ask her to get a CA125 blood test done. CA125 and HE4 are the two blood tests that are done for ovarian cysts. These are very sensitive for ovarian cancer. So why can't we use this as a screening test? Because it is seen only after the cancer is diagnosed that the CA125 will go up. So if I want to screen it, I have to screen it before my patient develops a big lesion. That is why the only possible test that we can do if you're suspecting ovarian cancer is one, genetic testing, two is doing a tumor marker like CA125 and HE4. So we do have genetic testing for ovarian cancer, the BRCA gene. So a lot of you would have heard of the actress Angelina Jolie. I'm not sure if any of you have not heard of her, but there is a famous actress called Angelina Jolie. If you know Brad Pitt, then you know Angelina Jolie. And what Angelina Jolie did was she did a bilateral prophylactic mastectomy. She took off both her breasts. Now, the reason she did this was because her mother and her aunt were both diagnosed with breast cancer. She went and got her genetic testing done and she found that she was BRCA2 gene positive. She was at high risk for breast cancer and hence she did something called as a risk reducing surgery. So risk reducing surgery is done for ovarian cancer and for breast cancer. We do genetic testing. If the genes are positive, then we go ahead and then we organ before the person develops cancer, which is exactly what Angelina Jolie did. She did a prophylactic mastectomy because she was gene positive for breast cancer. Now, I have a patient who has an ovarian cyst. Mother has had history of ovarian cancer. She comes to me and says, Doctor, I cannot afford genetic testing. It's too expensive for me. I know I have a high risk because my mother has ovarian cancer. What do I do? I tell the patient, see, I understand. So let's do an ultrasound and a CA125 blood test every year. Although this is not as effective as genetic testing in ovarian cancer, we can pick up very, very early lesions and treat it. See, I told you the problem with ovarian cancer is that it's diagnosed late and patients come in very advanced stages of cancer. But if we do these tests in early stages, we have a very good prognosis. So doing a transvaginal ultrasound and a CA125 is a good and effective screening test for ovarian cancer. Genetic counseling and risk reducing. So what do we do if the patient is positive for ovarian cancer gene? So let's say the girl comes and she says, I have the genes positive. My mother had breast cancer. What should I do? My mother had ovarian cancer. What should I do? Once she completes her family, we do a risk reducing salpingo-oophorectomy. We take out the ovaries. Just like Angelina Jolie took out her breast, we take out the ovaries in a patient who has ovarian cancer gene positive, mainly because we don't want them to develop the cancer that much later in life. So 1.4% of women in the general population will develop cancer, and up to 4% of women in the 40% of women with the BRCA gene mutation will develop cancer. So 1.4% of women in the general population and 40% of women who have the gene positive. So what to tell you the strength of genetic history. So if I have a patient who is in the general population, only 1% of those patients will develop ovarian cancer. That's sporadic. But genetic or family history is so important that the moment the genes are positive, the moment they're positive, 40% of these women will actually be diagnosed as having ovarian cancer. Endometrial cancer, most gynecological cancers in postmenopausal women, it's most common. And it is a relatively better cancer to have, which is a cancer of the body of the uterus. The reason is it's very easily picked up. If there's a growth in the uterus, the patient is going to come with abnormal bleeding, heavy bleeding, postmenopausal bleeding. Menopause means when periods have stopped for 1 year. So any patient who bleeds at the end of 1 year is postmenopausal bleeding, and postmenopausal bleeding is the most important symptom of endometrial cancer. There is no screening test because we do scans every year, and the moment the patient has a thickness on the scan, we say please do a biopsy because there could be a chance that something is growing inside the uterus. So there is no effective screening test like a pap smear. Still, doing an ultrasound for endometrial cancer is still good enough to screen in women who are at high risk for endometrial cancer. And biopsy is again the confirmatory, but it's like a small DNC where we clean up the uterus, remove a part of this tumor, give it to the lab for a test, and the lab will then confirm whether there are any signs of cancer or not. So most common cancer to have, very easy late stage of presentation, patient present with postmenopausal bleeding, no effective screening test, and it's usually done for high-risk patients. So in summary, I spoke about the endometrial, cervical, ovarian, and breast cancer. There are a lot of screening protocols. A lot of the Indian organizations, the UK organizations, the American organizations, all sum up to the same thing. In cervical cancer, the most important cancer screening test is pap smear, and this is recommended 3 years after sexual debut. Like I already mentioned, every woman after the age of 40 must undergo a cervical cancer screening with a pap smear every 3 years. Along with that, HPV DNA testing can also be done, which is slightly more expensive. And we have the HPV DNA self-testing, which is done nowadays. And for rural areas and rural settings, we do the VIA or the visual inspection under with acetic acid. For the breast self-examination, clinical breast examination by a trainer who could be a gynecologist or a surgeon, or doing a mammography or an MRI. Mammography is X-ray, although annually in certain parts of the world it is done every year. In India, we recommend to have it done every 2 years because of the increased exposure to the X-ray. MRI breast is also a screening tool for very complicated breast lesions. Ovarian cancer, basically, there's no good screening test. We do genetic screening in patients who are high risk for ovarian cancer. But if a patient is not affordable, every year doing an ultrasound, a transvaginal ultrasound with a serum CA125 blood test is a good enough screening test for ovarian cancer to pick up those early cases of cancer so we can treat them early before they come to us in advanced stages. Endometrial cancer, the only screening test is an ultrasound. We do a scan in any lady who comes with bleeding in the menopausal period. We say, look for the endometrial thickness. If the endometrium is very thick, we subject the patient to a biopsy. There are 2 or 3 cancers that I've not spoken about because they're not really gynec cancers, but they're very, very common among women. One, of course, is colonic cancer or colorectal cancer, skin cancer, and lung cancer. So these are the cancers that in the West or in America and UK, they screen for these cancers also every year. The skin, the lung, and the colon. In our country, our screening protocols are only limited to endometrium, cervix, ovary, and the breast, which is very important. But colonic cancer also is not very rare in our country. It is quite commonly seen, and it has to be screened. And how we do this is we look for the fecal occult blood test, can do a colonoscopy, but this is recommended in patients who are again gene positive. If somebody has a history of breast and ovarian cancer in the family and the colonic cancer gene is also positive, we would tell them undergo a colonoscopy every 5 or 10 years, depending on your family history. So in colon cancer, there is a connection between colon cancer, breast cancer, and ovarian cancer genetically. So a patient who has breast or ovarian cancer in the family or colonic cancer, even in the male relatives. So this is something that has to be understood. When I take family history for my patient, I don't only ask her about her mother, her sister, or her aunts. I also ask her about her father and her uncles because family history in the males of stomach cancer or colonic cancer has a high risk and it requires genetic screening and probably a colonoscopy or fecal occult blood testing. So lung, skin, and colon are cancers which are still very common in our country and require some amount of screening to be done. What's important is education. The reason why the word cancer scares everybody, the reason why the word biopsy scares everybody is because of misinformation. And with this era of where we have too much of information on the internet, on Instagram, on WhatsApp, sometimes the wrong information can spread much faster than the right information. So it's important that our patients know what the symptoms are and when they need to come to the hospital for an evaluation. Patients should understand that screening does not mean you have cancer. Screening means you're servicing your body before you develop any problem. You're picking up lesions at very, very small stages and you have a 100% cure if these lesions are actually fixed. So the common symptoms that I would want my patients, and this is a small chart that we place in our gynae-onco clinics so that if patients come in, they can see. In ovarian cancer, the most common symptom would be dyspepsia, indigestion, or gastritis, which does not respond to medicine. So if a patient is having indigestion for many years and gastritis for many years, I think most of us have this problem and we're going to end up thinking that, I hope I don't have ovarian cancer. But it is good to check and do an ultrasound and see that you have no cysts or any tumors on the ovary because that's one of the symptoms. Uterine cancer is bleeding. Cancer in the body of the uterus. Patient will come with bleeding, postmenopausal bleeding or bleeding between the cycles. Postcoital bleeding is a symptom of cervical cancer. So bleeding after intercourse is common in cervical cancer. Postmenopausal bleeding is common in uterine cancer. Vulva cancer, vaginal cancer are certain lesions or growths in the vulva vagina which look abnormal, which bleed on touch, could be cancer of the vulva and vagina, which are very, very, very rare. So a clinical scenario, how we see cervical cancer in our setting. One, a 35-year-old woman comes, she's married. Usually cervical cancer patients are multiparous. They have 7, 8 children. And that's why the risk of HPV infection in cervical cancer is much more because of more exposure to HPV. So she has 2 children. She complains of postcoital bleeding since 2 months and she's never undergone a cervical screening. She has no medical illness, no diabetes, hypertension. And this is how a common cervical cancer presents. There's a young lady, she has multiple children and she has postcoital bleeding. I would suspect cervical cancer because of the early age of sexual activity, multiparity, no screening has ever been done. Lots of HPV infection is there in average risk population. So the PAP, there is something called as a PAP gene test. So I told you about the PAP and the LBC cancer screening test. I said if there is a growth on the cervix, we take a biopsy. And I also talked about the HPV self-testing, which is a new test that has been discovered. But there's something called as the HPV-seq gene test. Now, HPV-seq gene test was discovered invented in John Hopkins. And what it did, it basically said that you come to the for genetic screening, and we take 3 samples. We use a tower brush and we sample the endometrium. We take a pap brush, a routine pap screening brush, and we sample the cervix. And then we also do a blood test and we look for the DNA of the ovarian cancer in the blood. So this is a triple gene test. We do take the liquid from these three places, and from this liquid we do genetic testing. So normally genetic testing is done from blood. We draw the blood and we test the genes. But this is called as a pap-seq gene test discovered in John Hopkins, where 3 levels of fluid are taken, and this is subjected to genetic testing. Now, the very, very important thing that has always been discussed and talked about is the HPV vaccine. And we know that from this year onwards, increasing awareness towards HPV infections and cervical cancer, the government of India has included the HPV vaccination now as a part of universal immunization schedule. Servavac is India's first indigenously produced cervical cancer vaccine. The earlier vaccines that were there for HPV or cervical cancer prevention were Servavac and Gardasil, which were foreign vaccines. But this year, the last few years, India has come up with its own indigenous cervical cancer vaccine, the HPV vaccination called as Servavac. The Servavac is given to girls between the age of 9 to 25, 2 doses, and 9 to 15 will be 2 doses, and 15 to 25 would be 3 doses. And that's how the vaccine is given. 90% of HPV causes cervical cancer. 90% of them also cause AIDS. So it's not that it protects only against cervical cancer. Even the boys are encouraged to take cervical cancer the HPV vaccination, because it can cause penile cancer and anal warts. Because the HPV virus, which is known to cause cervical cancer, also causes penile cancer and warts. So that's why the HPV vaccination protects against mouth cancer, throat cancer, anal cancer, penile cancer, and genital warts. But we use it for prevention of cervical cancer among our young girls. So the HPV vaccination recommended for all girls to prevent cervical cancer in India. 1 or 2 doses in the up to 15 years of age, and 3 doses to be given above 15 years of age up to 25, and also immunocompromised individuals. So another case, and this is a case scenario for screening for cervical cancer. What we do in a woman who comes with post-coital bleeding is we are subjected to a pap smear HPV DNA testing. And if the HPV pap smear is normal, the abnormal pap smear report says HSIL, then we subject the patient to a biopsy. So the moment we see that, so what next? So if my patient comes and asks me, I'm going to come for cervical cancer screening, but what do I do if my pap smear is abnormal? And I would tell her, if the pap smear comes abnormal, it doesn't mean that you have cancer. We have to do confirmatory test, which is like a colposcopy, where we use a magnifying glass and see the cervix, and we take a biopsy. So a colposcopy guided biopsy would be the next test in any patient who has an abnormal pap smear. So the key learning points are, we must never include, so cervical cancer happens in young patients. Breast cancer happens in relatively young patients. So we can never say, oh, you're so young, you'll never have anything. So cervical cancer, any kind of abnormal bleeding or postcoital bleeding cannot be ignored. Why do we do this cancer test? Is not to pick up cancer, but to pick up pre-cancerous lesions that can later become cancer. We tackle it or take care of it right at the beginning. And when we detect it early, we can do conservative management. We don't have to remove the uterus of the patient just because we suspect cervical cancer. We can just remove that lesion and do a conservative management. And regular screening prevents invasive cancer. This is the dictum that we have to understand. Why should we regular screen? We do regularly screen not to prevent cancer, but to prevent invasive cancer, a cancer that goes and gets spread and metastasizes. We can prevent this cancer by doing regular screening. Ovarian cancer, the classical scenario, 52-year-old woman, postmenopausal, her periods have stopped, she's 50 plus, she has bloating, indigestion, gastritis, it's not responding to antacids for many months. She comes to the doctor and she says, see, I have no bleeding, my menopause has happened, but I'm having this bloating and gastritis all the time. What should I do? I have no family history of cancer as well. I would subject her to an ultrasound and for non-specific gastrointestinal symptoms. If the woman is postmenopausal, ovarian cancer is highly suspicious. So cervical cancer, breast cancer happens in younger individuals. Ovarian cancer happens in older women. It doesn't mean that ovarian cancer cannot happen in young women. We do see unfortunately see a lot of young women ovarian cancer as well, especially with increasing incidence of IVF and fertility treatment nowadays. We have to keep in mind that there is an increased rise of ovarian cancer. But postmenopausal women always have a very high suspicion. If they have an ovarian cyst, we always have to think of ovarian cancer. They present late, and that's something that we should keep in mind. And there is no good screening test other than genetic screening or doing a serum CA125 and an ultrasound. So what do I do if I suspect in my postmenopausal women, I subject it to an ultrasound, I do a CA125, I examine my patient and see whether I can feel the cyst. And if it is a very severe and a very big tumor, it has spread to different parts of the body, then the oncologist or the oncosurgeon would need to take care of this. And that is why screening is very important to pick up what kind of lesion that the patient has. So ovarian cancer, no real screening test. Patient comes indigestion that is not responding to antacids, and I would do an examination, an ultrasound, and a serum CA-125 examination. So I always have a high index of suspicion and educating women about the warning symptom, which is indigestion of gastritis, which does not respond to antacids, is very, very important. So overall, I only spoke about cervical. So you would have noticed that I spoke about cervical and breast cancer the most because breast examination, mammography, and pap smear are the two tests which are a part of a women's health checkup. So usually I tell my patients this, if somebody's around, they would know I rattle on this like a parrot. I say, do a women's health check after the age of 40 every 2 years. In your women's health checkup, you must include your breast scan, a scan of your abdomen and pelvis, a pap smear testing, which is very, very important. Do your blood test like your thyroid, your vitamin D, your cholesterol levels, because it's also a very important part of screening. And that's how it is. So do screening for ovarian and for breast cancer, cervical and breast cancer is a part of the women's health checkup. Breast and ovarian cancer is more based on the positive family history. Now, what are the challenges in screening? Why is screening not very effective in our country? I told you less than 40% of women actually undergo effective screening. Why is it that not effective? The reason is barriers to access, socioeconomic status. Patients think only if I have a problem, I'll go to the hospital. Why should I spend? Why should I spend 1,000, 2,000 bucks on a health checkup when I'm feeling perfectly fine? So the reason is you want to pick up the lesions or pick up the problem before it becomes a big problem. So misconceptions about screening is what is going on. And I told you screening or cancer testing, when we tell patients, it scares them a lot. And we have to get rid of these misconceptions. A lot of celebrities, Indian celebrities, have been diagnosed with different types of cancers, and they have gone on and spoken about this. Another way of reaching out, only to tell you that it's not, even celebrities are not, debarred from having cancer. No matter how great or how, although lifestyle does matter, it really, really matters that, your genetics also can predispose you to cancer. So nobody is safe from this. But a lot of young celebrities have gone on and talk about cancer, especially Manisha Koirala for ovarian cancer, Lisa Ray for ovarian cancer, Yuvraj Singh for lung cancer. They have gone out, spoken about this, started organizations to increase awareness, and they encourage different forms of cancer screening. The role of your gynecologist or your doctor who you visit once in a while is that they would identify these patients who have family history, identify patients who have abnormal symptoms, risk factors, gastritis, bleeding, and counsel them and tell them that please undergo a health check. And this is where we come in. We tell you undergo a health checkup every 3 years or 2 years after the age of 40. Do your pap smears, do your breast examinations. Pap smears don't hurt. We don't have to do a biopsy, just do the screening test. You educate women about the warming symptoms and you continuously follow them up. Now, based on the ages, so I'm not telling you everybody undergo a mammography, everybody undergo a pap smear. No, less than 25 or 30 years, we don't recommend a pap smear. After the age of 35 or 40, we do a pap smear every 3 years. Similarly, screening for doing a mammogram is after the age of 45 or 50. Do a breast ultrasound after the age of 35. So, depending on your age category, your doctor would recommend what screening tests are appropriate for you. So, it's not like one shirt fits all. And depending on the age of the patient, we would recommend the screening test for that particular age group, depending on the family history of the patient. So I have two patients, two 18-year-old young girls. One person's mother has had breast cancer, the other person's mother is normal. I would ask the first patient that please undergo breast ultrasound every year. I wouldn't do a mammogram for her because it's an X-ray and she's young. But I would tell her, please do your genetic screening, look for breast cancer genes, or do your ultrasound and look at your breast every year. So that's what this chart basically tells you. Also tells you about another elephant in the room. So India is now officially the diabetic capital of the world. Diabetes, hypertension, cardiac disorders, and metabolic problems, which happens because of obesity, increased abdominal fat, are now a new norm. Every alternate person, young individuals in 25s and 35s, are having cholesterol, having heart disease, hypertension, etc. This is again purely because of our lifestyle and because of the changing trends and times in which we live. But as a part of screening, it's not just cancer, but even lifestyle diseases. And that's my second take home message today. It's not just about cervical cancer or breast cancer screening. It's also that as an individual, you have to check your blood pressure, your cholesterol, your thyroid, your vitamin D levels, every 2 years. So it's very important to do your health checkup once a year, a blood checkup, and look for these signs of cholesterol, high blood pressure, because these are the new endemic diseases in our country. So as I move to the end of my presentation, what we don't know how strong we are until being strong is the only choice we have. And this is what cancer does to cancer survivors. We don't realize that, okay, we have this power in our hands to do the screening test, to do the testing every 2 years and every 3 years. We don't do it because for many reasons. We're busy, we're running in the race of time. We think there's no way I can get cancer. I mean, how is that even possible? I don't have a family history. But then it comes to a point where we are, pushed towards the wall and we have to be strong. So that's what cervical cancer screening teaches us, that you don't know how strong we are until being strong is the only actual choice that we have. My take home messages are that cervical and breast cancer have effective screening programs in our country. Do your pap smears, encourage people, your loved ones, your family members to do their pap smears, do their mammograms and their breast ultrasounds. Population based screening is required. We don't do colonic cancer screening in our population. We do more of cervical and breast cancer screening. Ovarian cancer has no effective screening test. Keep this in mind. Do an ultrasound if there is anybody who has symptoms of gastritis and indigestion, and we can pick up lesions very, very early in early stages. And screening saves lives. Cervical and breast cancer screening are our priorities. We cannot ignore endometrial and ovarian cancer as well. Increasing awareness and increasing access, the two A's. We have to make sure that our population is aware that these things are there. Screening tests are available even in PHCs. Pap smear tests are even available in PHCs. The second thing is we have to make sure that access is there. The treatments are very accessible. We need to do a regular follow-up to ensure success, and we encourage women to be very proactive. See, the women in our country, especially in India, generally women all over the world and women in India are known for two things. One is multitasking, doing 10 things at one time. I'm sure all the women in the group will agree with me that multitasking is a gene that has been given to us by default. And even right now when I'm doing this, I'm looking at my phone, I'm organizing something. So that's something that comes with us all the time. Our moms, our grandmas, our teachers, all of them do multitasking. The second thing about Indian women and most of us women is we do not look at our health as priority. We look at our families, our husbands, our brothers, our mums, our children, and last in the priority list is our health. So this is something that needs to change. We need to focus ourselves. First, love yourself or fly is what I tell patients all the time. Look at your health and focus on your health and be proactive, because only if you look after yourself well will you be able to look after your family members and your loved ones. So we have to encourage women to be very proactive in their health maintenance. With this, I would like to conclude my talk on screening for cervical cancers. I hope I have managed to do justice, and I will happy to answer any kind of questions. I thank you, Harshita ma'am, for giving me this opportunity. And the group is now open for discussion. Thank you.
Thank you, ma'am, for a very insightful session. Now, participants are kindly requested to raise their questions. Yes. Yeah. Madam, there is a question. Mammography or Doppler sonography, which is better for regular?
X-ray. You take an X-ray of the ultrasound is doing a scan. Now the thing is, mammography is effective and is very good, but the breast tissue is very dense. So above the age of 45 and 50, mammography is slightly much better than an ultrasound. But the common problem now, even with the latest mammography machines, mammograms are painful. For those of you who have undergone it, more painful. So what happens is, I want my patient to do a screening test every year or every 2 years. My patient is not going to come back thinking about the pain. So this is a practical problem, and it's not as the textbooks or the guidelines say, do a mammogram. There's no doubt about it. But in practice, I tell my patients, see, if you find it too painful, at least do a breast ultrasound every year. Ultrasound waves are safe. They're like a pregnancy scan. It's not Doppler. Doppler means checking blood flow. We don't do Doppler in the breast. We do an ultrasound in the breast. The ultrasound of the breast is safe. I can do it every month, every year, and it's not painful. So if I had to see the effectiveness, the mammogram is more effective. But if I had to see comfort and repeatedness, if I want to repetitively want to do a test, I would say the ultrasound is the best. So what I generally follow in practice is a woman above the age of 40 can breast extremely obese, etc. But a woman above age 35, no real family history. I did a clinical examination. I didn't find a lump, and she's just doing it for screening. I do an ultrasound of the breast because I don't want her to think about the pain of a mammogram and never come back again. So this is a practical thing. Maybe the guidelines is going to say otherwise, but this is what I follow in practice. It's better to have some form of screening than have no screening at all. You don't want to come to the hospital thinking of pain and on a routine checkup, and then you rather do some kind of screening. So I would personally recommend doing an ultrasound in the younger age group rather than a mammogram.
Thank you, ma'am. Ma'am, there is another question by Paulmi Saha. Till what extent does a PET scan affect the overall health of a patient? It's in the chat box.
not sure exactly why this question has come up, because a PET scan is a scan done. It's basically we looking test. A PET cannot be used as a screening test because one, it is expensive, it is not accessible, it has involves a high dose of radiation, so we cannot do it repeatedly. And PET is done only if you're suspecting that there is a tumor somewhere and you want to see the spread. Let's say somebody has a breast lump and I'm planning a breast lump surgery on her and I want to check if it is a cancerous lesion, it has spread. I would do a PET scan to give me the suspicion about, how suspicious that lump is. So a PET scan is not routinely done, and to tell you how it affects the body, it's something that shouldn't be done unless it's absolutely required because it's a high dose of radiation.
Yes. There is a question.
There is always a chance of recurrence, but with they say if it's an early stage cancer, a mild type of cancer, where a mild and not an aggressive tumor, you give chemotherapy, radiation. There have been instances where there has been no recurrence at all. So it's difficult to give. It's not one shot fits all. This is difficult to give you a complete idea of when it's going to recur. It depends upon the pathology report. Depends on the receptor. There's something called receptor status that we check. It depends upon what kind of a tumor is it. Is it an aggressive tumor? And what kind of surgery was done, how fast the treatment was given. It depends on all these things. So if the tumor is a mildly aggressive one and complete treatment with chemotherapy, radiation has been done, then the chance of that tumor recurring is very, very less.
Uh, Thank you, ma'am. One more question, ma'am, by Vidya Desai. Ma'am, when I do moderate exercise, which focuses on reducing my belly, sometimes I get white discharge and I feel weak. Is it normal?
So, ma'am, exercise cannot have this kind of a side effect where you have, excessive white discharge. There are various reasons for white discharge. For some people, white discharge is normal, and for a lot of patients, a lot of people, white discharge can be infections like fungal infections, etc. Any kind of discharge which is bothering you, which is more than your regular, which is hampering your regular activities, requires to be checked. Exercise per se cannot cause white discharge. I recommend that you continue doing your exercise, moderate exercise on your belly exercise is very, very good to reduce central abdominal fat. Do not stop it. And white discharge as such cannot have any connection with that. There could be discharge collecting on the inside, which could be an infection or some other reason. Best to consult your doctor and get it checked out.
Tinkle Patel has asked, is HPV vaccine is effective in women who is sexually active?
Ma'am, this is a very good question. I thank you for this. I did not elaborate this because HPV vaccination is a separate topic by itself. And also, HPV vaccination is ideally given between the age of 9 to 25. Now, 9 to 15-year-old young girls, we give this vaccination to prevent cervical cancer in their adulthood. 15 to 25 years, we tell them to take 3 doses. Now, in women who are above the age of 30, so I told you it is common in younger people, and cervical cancer is more commonly seen in women above the age of 35. Then why not give them the vaccine? Because after the age of 35, women are already exposed to HPV. So the effectiveness of the vaccine is less. Although we still give, there are some women who say, no, I want to take the vaccine. They can still take the vaccine. But by the rule, after the age of 35, even if you take the vaccine, your pap smear screening has to be done. So it doesn't mean I've taken the vaccine, I shouldn't do the pap smear screening. No. The HPV has strains, and the HPV vaccination protects you against certain strains. But there are still certain strains which the protection is not there against. So that is why when a woman has taken a vaccination, it doesn't mean after she crosses her 35, she should not do pap smear screening test. She should do a pap test for cervical cancer after the age of 35, irrespective of whether she has taken the vaccine or not. And above the age of 35, in women who are sexually active, it is not very effective, but the vaccine can be taken. It's not that it cannot be taken, but the effectiveness is less.
Okay, thank you, ma'am. Ma'am, Vidya Desai, madam, has asked, what exercise would you suggest for lifting breast and strengthening muscles?
See, ma'am, again, the kind of exercises that people do depend on a multiple factors. Depends on their overall health, whether they have any kind of joint pains and things like that. Depends on their age. So the exercise that a 30-year-old or 40-year-old does is different from the exercise that a 50-year-old does. Secondly, it is that. And yeah, those are the two main things. And of course, targeting, I would recommend doing exercise different parts of the body every day. Like one day of your hands, one day your legs, and those kind of things. And work on your core or your abdominal exercises are the most. Other than that, I mean, there are a lot of exercises that people do. You can do upper arm exercises, especially for strength training, things that strengthen your triceps and your biceps. So that I think is something that is widely available all over. But upper limb exercises do help in strengthening muscles and the breast. light amount of weights. So the after the age of 40, at least 3 times a week, a little bit of doing weights. I'm not saying big, lifting dumbbells, like big dumbbells, but a little bit of weight training exercises do help for the upper part of the body.
Yes, ma'am. Madam Sanjana has asked, ma'am, is it possible to have cancer if your father has suffered from an abdominal cancer?
So that's the thing. So unless we do genetics testing, ma'am, we wouldn't know. But if there is a first degree relative and a father is a first degree relative has colonic cancer or gastric cancer, I would recommend if the patient is affordable, get your genes tested, do a genetic screening because there could be a chance. But a good number, see any type of cancer, whether it's a colon or the ovary or the breast, there are two kinds. One is sporadic, one is genetic. Now, what is sporadic? Sporadic is there are 10 people sitting in a room and randomly one patient gets cancer. So that is sporadic. But genetic is connected to each other. So now I don't know whether that abdominal cancer in the father is genetic or sporadic. So how can you make that out? You have to go and check your genes, do genetic testing and do your screening test every year and be keep in mind that you're high risk. When you have a father, mother who has breast, abdominal cancer, you are high risk. So every year do your screening test and if it's affordable and feasible, do a genetic screening test and check your genes and check if you have the genes for cancer as well.
Madam Nilima Goswami has asked, after menopause frequently, UTI is normal.
So, ma'am, UTI is not normal in the sense that you shouldn't be having a urinary tract infection or UTI, but it is very common. It's very common because of vaginal dryness. In the heat, people forget to drink water, and mainly because of menopause and vaginal dryness, infections are common. But there is a way to go about it. You should get your infections treated. Continuous infections are not good. It can affect your kidneys. So, you have to get a urinary infection treated if it's happening too frequently. Yeah, it is quite common to have urinary infections after menopause.
Ma'am, there is a question from Lata Ben Panchal. Water bottles with 500 ml to 1 liter water can work for weightlifting.
I think that's not a question, and she's probably telling us, but yeah, it does. People do this. People who don't want to lift dumbbells or weights do this. Any kind of upper limb exercise with weights are effective. I think she's sharing, and she's not. It's not a question, ma'am.
Okay. Thank you, ma'am. Uh, Participants, if you have any other question, you can unmute and you can ask, ma'am. Audio has been enabled. Ma'am, there's a question from Swati. What not to do to maintain hygiene in vagina and all private parts? Sometimes I feel itching in vagina.
Vaginal hygiene is very important. One, of course, is that using any kind of lubricating creams or abnormal chemicals in the vaginal area is not recommended. Other thing is vaginal wash solutions can be used, especially if you're traveling, you'll be using common washrooms. Maintain your hydration. So, the most common reason why people develop vaginal infections are because of heat and inadequate water intake. So, it's important to maintain your hydration and drink lots of water. Otherwise, you don't have to use any fancy soaps or washes for the vaginal area. Basically using normal water, lukewarm water to clean the vaginal area, keep it dry, very, very important. Sanitary napkins disposal and changing sanitary napkins frequently in patients who do get their periods is very, very important. So a few things are basically maintaining hygiene. Don't use repeated use of razors, unhealthy chemicals or any kind of things in the vaginal area should be avoided. And if there's itching which is really bothering you, then it's best to consult your gynecologist because it could be a fungal infection and you would need an antifungal treatment for this.
Ma'am, Naveen has asked, is there a association between breast cancer and not feeding milk to the child?
So again, very interesting question, ma'am. And thank you for this question because it's something that really a lot of patients do ask. One thing is a lot of mothers are not able to breastfeed, and this is something that they do not have to feel guilty about because of a lot of medical problems. Sometimes there's no breast milk and they can't feed. Although this is very rare, it's very important that they should not feel guilty about this. And a lot of people say that if you don't feed, you're going to get cancer, which is not true. It's a myth. In fact, breast cancer is the most common and more common among women who don't have children and who are nulliparous. It doesn't mean everybody who doesn't have a child will get breast cancer. That is also wrong. But if you compare people who've had children and people who are nulliparous, people who are nulliparous and have not given childbirth have higher incidence of breast cancer. That's why we worry about breast cancer among nun sisters and people who are not really married and don't have children. It's more common. So breastfeeding has nothing to do with our breast, but there is a school of thought that says that if you breastfeed, It protects you against breast cancer, but it doesn't mean that if you don't feed, you will get breast cancer. These are two different things. If you feed, there is a chance that you will, lesser chance of breast cancer, maybe by 5 or 10%. But it doesn't mean that if you don't feed, you're going to get breast cancer. That's a myth.
Madam, a question by Miss Mabel. HPV doses, what is the gap between the doses?
So, in children between 9 to 15 years, we give 2 doses, and 15 to 25, we give 3 doses. So, the first 2 doses is 0 and 6, and when we give 3 doses, is 0, 2, and 6. So, 9 to 15 is 0 and 6 months, and from 15 to 25, we give 0, 2, and 6 months.
Ma'am, one last question by Vidya Desai. Is V-wash usage for cleaning vaginal area safe?
So V-Wash is a vaginal wash. It's a brand, but there are many vaginal wash solutions, and these are not dangerous. But the thing is, some people excessively use it. They use it like 4 5 times a day. What happens if you use a face wash 4 5 times a day? You're going to cause a lot of dryness. The same thing happens in the vagina. Ideally, you don't always require vaginal wash. Using clean water, keeping it dry is enough for the vagina usually. But if you do use a vaginal wash solution, it's not unsafe, and just make sure they don't use it repeatedly or overuse it.
Yes, ma'am. Uh, Thank you, ma'am, for answering all the questions of our participants. Now, I request all the participants to switch on their camera for a group photo. Before the vote of thanks, I request all the participants to switch on the camera for a group photo. I'm taking some screenshots. Thank you. On behalf of SDM College of Business Management, Postgraduate Center for Management Studies and Research, I extend our heartfelt gratitude to Dr. Joylyn Almeida for graciously sharing her valuable time and expertise with us today. Ma'am, your insightful session was enriching, inspiring, and highly informative. And you have offered a practical perspective which you have drawn from your vast clinical experience. We are greatly thankful to you, madam. And Dr. Joylin, you have made this session a truly impactful one and memorable one. Thank you, madam.
Thank you, ma'am. Thank you for the opportunity. There are some questions in the chat box. I will reply
Yes,
to you
ma'am.
in because there's
Yeah.
a shortage. Thank you.
I extend my sincere thanks to all the participants for your active and enthusiastic participation. Your keen interest and insightful questions have made this session truly memorable. Thank you. Now, participants, kindly note the feedback link will be shared in the chat box as well as in the WhatsApp group. Yes, kindly fill it. Participants, kindly note our fourth session, that is healing through movement, dance for mental health and emotional expression. We'll be starting at sharp 11:30.